don't stop. Don't stop. Don't stop. Don't stop.
Palate, pharynx, esophagus. 1. The palate forms the roof of the mouth, separating the nasal from the oral cavity. The anterior portion is bony and is called the hard palate, whereas the posterior portion is without bone and is called the soft palate. The palate forms the roof of the mouth and the floor of the nasal cavities. It consists of two regions, one containing a bony shelf, the immovable hard palate, and the other, a more posteriorly located, muscular, movable soft palate. Hard palate. The hard palate composed of the palatine processes of the maxillae fused with the horizontal processes of the palatine bone. Anteriorly it is bounded by the alveolar arch and posteriorly it ends wherethe soft palate beggins. The hard palate is a bony plate composed of the palatine processes of the maxillae and the horizontal processes of the palatine bones fused in the midline with their counterparts of the opposite side. Anteriorly and laterally, it is bounded by the alveolar arches, and posteriorly its boundary is demarcated by the beginning of the soft palate. The bone is covered by a specialized mucoperiosteum on both its oral and nasal surfaces. The posterior border of the hard palate possesses the palatine aponeurosis for attachment of the muscles of the soft palate. The oral aspect of the hard palate may be divided into several regions according to the composition of its soft tissues. Hence, the median raphe region, along the palatal midline, the anterolateral adipose region, and the posterolateral glandular region are recognized as regions of the hard palate. Soft palate. The soft palate is a muscular structure suspended between the oral pharynx and nasal pharynx. Since it is flexible, it may be elevated to isolate the oral cavity. The soft palate is a muscular structure, encased in a mucous membrane, suspended between the oral pharynx and the nasal pharynx. Its sides are attached to the lateral pharyngeal walls. The anterior portion of the soft palate, near its junction with the hard palate, is almost immobile, whereas its posterior-most extent, the uvula, is capable of great excursion. Lateral to the uvula is the palatoglossal arch, palatoglossal fold, containing the palatoglossal muscle, forming the anterior pillar of the oropharyngeal isthmus, fosses, extending into the side of the tongue. Arising posteriorly is the palatopharyngeal arch, containing the palatopharyngeus muscle, forming the posterior pillar of the oropharyngeal isthmus extending into the lateral pharyngeal wall. The palatine tonsils are located between the two fosses in the tonsillar sinus. Muscles of the soft palate. 5 muscles are associated with the soft palate. These include muscles that originate outside of the soft palate proper and insert into it, and other muscles that originate in the soft palate and insert into the palatal tori. Osseous protrusions, palatal tori, may be observed on the hard palate. These tori, usually bilateral, are asymptomatic, although they can interfere with fitting of maxillary dentures. They may need to be excised surgically before the taking of impressions. Soft palate. The soft palate is a movable structure and must be avoided by the posterior aspect of a maxillary denture because its muscular action will break the palatal seal and dislodge the prosthesis. The posterior aspect of the soft palate is sensitive to touch and may induce vomiting on tactile stimulation. Tongue and/or pharyngeal wall. All are innervated by vagal contributions to the pharyngeal plexus except the tensor veli palatine, which is innervated by the mandibular division of the trigeminal nerve. The muscles of the soft palate are the levator veli palatini, tensor veli palatini, musculus uvuli, palatoglossus, and palatopharyngeus. Levator veli palatini. The levator veli palatini is a thick, pencil-shaped muscle that is intimately associated with the lateral aspect of the choana. It has 3 regions of origin, 1 tendinous and 2 fleshy. The tendinous origin is the inferior aspect of the petrous portion of the temporal bone on the proximal aspect of the apex just anteromedial to the entrance into the carotid canal. The fleshy origins are from the tympanic part of the temporal bone and from the cartilage of the auditory tube. The muscle fibers are directed medially, between the salpingopharyngeus and tensor veli palatini muscles, to insert into the palatal aponeurosis, passing between the two layers of the palatopharyngeus muscle. As the levator inserts into the soft palate, its muscle fibers interdigitate with those of its counterpart from the other side. This muscle is innervated by the vagus nerve via its contributions to the pharyngeal plexus. The levator veli palatini, as its name implies, elevates the soft palate. Tensor veli palatine. The tensor veli palatini, a pyramid-shaped muscle, is situated anterior to the levator veli palatini and medial to the medial pterygoid muscle. It originates in the scaphoid fossa, on the spine of the sphenoid bone, and the cartilaginous portion of the auditory tube. The fibers collect into a tendinous cord that wraps medially around the hamulus of the medial pterygoid plate to insert into the palatine aponeurosis. The tensor veli palatini is innervated by a branch of the nerve to the medial pterygoid, arising from the mandibular division of the trigeminal nerve. This muscle acts to flatten and tense the soft palate. Musculus uvuli. The musculus uvuli is a small, thin muscle lying between the two layers of the palatine aponeurosis. The muscle originates on the posterior nasal spine of the palatine bone and from the palatine aponeurosis to insert in common with its counterpart from the opposite side, forming the substance of the uvula. The musculus uvuli is innervated by the vagus nerve via its contributions to branches of the pharyngeal plexus. It acts to retract and elevate the uvula. Palatoglossus. The palatoglossus muscle, a small, longitudinally disposed muscle, is overlaid by a mucous membrane, thus forming the palatoglossal arch. It is a thin, cylindrical muscle originating in the fascia and musculature of the lateral aspect of the soft palate. It inserts by interdigitating with the intrinsic muscles of the tongue in its lateral margin. Motor innervation to the muscle is derived from the vagus nerve via its contributions to branches of the pharyngeal plexus. The palatoglossus acts to elevate the posterior one-third of the tongue and, acting with its counterpart on the other side, constricts the fauces. Palatopharyngeus. The palatopharyngeus muscle and its mucosal covering form the palatopharyngeal arch. It is a long, thin, cylindrical muscle arising by two fleshy slips from the side of the soft palate, with the levator veli palatini and the musculus uvuli being interposed between the two origins. The muscle inserts, along with fibers of the stylopharyngeus muscle, into the posterior aspect of the thyroid cartilage and also into the muscular coat of the Pharynx. The palatopharyngeus receives its motor fibers from the vagus nerve via its contributions to branches of the pharyngeal plexus. This muscle functions to elevate the pharynx and larynx and to assist in closing the oropharyngeal isthmus. Vascular and sensory nerve supply. Vascular supply. The major vascular supply to the palate is provided by the greater and lesser palatine arteries, branches of the maxillary artery, whereas minor contributions are from the ascending palatine branch of the facial artery and the ascending pharyngeal branch of the external carotid artery. The vascular supply of the palate is derived chiefly from the greater and lesser palatine branches of the maxillary artery, the ascending palatine branch of the facial artery, and the ascending pharyngeal artery from the external carotid artery. The greater and lesser palatine arteries descend in the pterygopalatine canal to enter the palate via the greater and lesser palatine foramina, respectively. The greater palatine artery passes anteriorly on the lateral aspect of the hard palate to supply the palatal mucosa, gingiva, and glands, and then proceeds to anastomose with the nasopalatine artery in the incisive canal. The lesser palatine artery vascularizes the soft palate and tonsil and then anastomoses with the ascending palatine branch of the facial artery. The lesser palatine bifurcates, and one branch travels along the surface of the levator veli palatini muscle to vascularize the soft palate. The other branch perforates the superior constrictor muscle to serve the auditory tube and the tonsil. The ascending pharyngeal artery from the external carotid artery travels along the lateral external surface of the superior constrictor muscle, reaches the levator veli palatini muscle, and gives off a palatine branch to serve the tonsil, auditory tube, and soft palate. Venous drainage is by similarly named veins that are tributaries of the pterygoid and tonsillar plexus. Sensory nerve supply. The major sensory nerve supply to the palate is provided by the greater and lesser palatine branches of the maxillary division of the trigeminal nerve as well as from its nasopalatine nerve. Sensory nerve supply of the palate is derived chiefly from the greater and lesser palatine branches of the maxillary division of the trigeminal nerve, which also carry sensory fibers from the facial nerve via the greater petrosal nerve. Additional sensory supply is derived from the nasopalatine nerve of the posterior-superior nasal branch of the maxillary division of the trigeminal nerve and the tonsillar branches of the glossopharyngeal nerve. Palatine tonsil. The palatine tonsil is a lymphoid mass that lies within a sinus between the palatoglossal and palatopharyngeal arches. It is a part of the walled eye ring, which guards the oropharyngeal entrance. The tonsil is richly vascularized and receives its nerve supply by the tonsillar branches from the glossopharyngeal nerve. The palatine tonsil, located in the tonsillar sinus between the palatoglossal and palatopharyngeal arches, is an almond-shaped mass of lymphoid tissue-covered palatine tonsils. The palatine tonsils of a child are much larger than those of an adult. They are prone to infection because they tend to accumulate debris in the tonsillar crypts. Frequent tonsillitis may indicate the need for tonsillectomy, a relatively minor surgical procedure in children. However, the proximity of the tonsils to the common carotid artery and the rich vascular supply of the tonsils necessitate extreme care in the procedure. Moreover, the glossopharyngeal nerve as well as an unusually tortuous internal carotid artery may also be vulnerable to injury by mucous membrane. The palatine tonsil is smaller than the tonsillar sinus, and the small triangular recess above the tonsil is the supratonsillar fossa. However, it has been suggested that this is a misnomer because tonsillar tissue surrounds this space and thus this recess is merely a large intratonsillar cleft. The medial surface of the tonsil is visible when the tongue is depressed, and presents tonsillar crypts that may invade nearly the entire depth of the tonsil. The lateral or deep surface is covered by a fibrous capsule, separating the tonsil from the pharyngeal musculature. The palatine tonsil forms a part of the tonsillar circle, the walled eye ring, which guards the oropharyngeal entrance. Arterial supply to the palatine tonsil is derived from branches of 4 arteries. The facial artery via its tonsillar branch is the chief vascular supplier of the tonsil, but this artery also makes a minor contribution via its ascending palatine branch. Other minor vessels serving the palatine tonsil are the palatine branch of the ascending pharyngeal, the lesser palatine branch of the maxillary artery, and the tonsillar twig from the dorsal lingual branch of the lingual artery. Venous drainage is by way of the tonsillar plexus of veins on the deep aspect of the tonsil, a tributary of the pharyngeal venous plexus, and the facial vein. Sensory innervation to the palatine tonsil is from the glossopharyngeal nerve and the lesser palatine branches of the maxillary division of the trigeminal nerve. Contributions are also derived from the greater petrosal branch of the facial nerve via the trigeminal nerve. The pharynx. The pharynx extends from the base of the skull to become continuous with the esophagus. It is divided into the nasal, oral, and laryngeal parts. The basic muscular wall is composed of the constrictor muscles that resemble a telescoped fibromuscular tube. The pharynx is a fibromuscular tube, 12 to 14 centimeters long, extending from the base of the skull to become continuous with the esophagus. It is broadest at its cranial extent and narrowest at its esophageal junction. Superiorly, it is attached to the basilar part of the occipital bone and the body of the sphenoid bone. Laterally, it is fixed to the medial pterygoid plate, pterygomandibular raphe, alveolar process of the mandible, lateral aspect of the tongue, hyoid bone, and thyroid and cricoid cartilages. Posteriorly, the pharynx approximates the bodies of the first 6 cervical vertebrae, being separated from them by the prevertebral fascia. Anteriorly, the pharynx has no complete wall, instead, it opens into the nasal, oral, and laryngeal cavities. Consequently, the pharynx is conveniently divided into nasal, oral, and laryngeal parts. Nasal pharynx. The nasal pharynx is the superior-most portion of the pharynx. It communicates with the oral pharynx via the pharyngeal isthmus, which can be sealed by the soft palate. It also communicates with the auditory tube. The posterior wall contains the pharyngeal tonsil. The nasal pharynx is the superiormost and broadest region of the pharynx. Its walls are rigid and present, on the two lateral aspects, several elevations. Anteriorly, it begins at the paired choanae, inferiorly, it is limited by the soft palate. During respiration, the soft palate is flaccid and the nasal pharynx communicates with the oral pharynx through the pharyngeal isthmus, a space between the posterior wall of the pharynx and the free border of the soft palate. During deglutition, the soft palate is elevated and contacts the posterior wall of the pharynx, blocking the communication between the nasal and oral cavities. The lateral wall of the nasal pharynx presents an opening, the ostium of the auditory tube, which is located infero-posterior to the inferior nasal concha. This ostium is located on the medial end of the cartilaginous auditory tube, which, protruding into the nasal pharynx, forms an elevation called the torus tubarium. Behind the torus is the pharyngeal recess, a mucosa-lined space extending to the base of the skull. Two folds extend from the torus. The smaller salpingopalatal fold covers the levator veli palatini muscle, extending from below the ostium of the internal auditory tube to the root of the soft palate, and the larger salpingopharyngeal fold covers the salpingopharyngeus muscle, extending from the postero-inferior aspect of the torus and passing inferiorly, becoming indistinguishable as the muscle merges with the muscles of the pharynx. The posterior wall of the nasopharynx contains a mass of lymphatic tissue, the pharyngeal tonsil. Adenoids. Adenoids is the term that commonly refers to the pathologic state when the pharyngeal tonsil becomes hypertrophied due to infection. Excessive hypertrophy partially, or completely, blocks the posterior choanae, necessitating mouth breathing and causing nasal speech and loud snoring during sleep. Persistent inflammation and infection of the pharyngeal tonsil may lead to spreading of the infection into the internal auditory tube, resulting in otitis media, with subsequent temporary or permanent hearing loss. The infection may eventually reach the mastoid air cells. Although in the past this was a relatively common disease, treated with mastoidectomy, the advent of antibiotics has done much to control and subdue it. Oral pharynx. The oral pharynx extends from the soft palate to the epiglottis and contains the palatine tonsil. The oral pharynx is relatively uncomplicated, being that portion of the chamber that leads into the laryngeal pharynx. It extends from the soft palate to the cranial aspect of the epiglottis, which is positioned at the level of the hyoid bone. Anteriorly, the oral pharynx begins at the oral cavity via the oropharyngeal isthmus. The lateral wall of the oral pharynx presents the palatine tonsil between the palatoglossal and palatopharyngeal arches. Laryngeal pharynx. The laryngeal pharynx begins at the epiglottis and becomes continuous with the esophagus at the inferior border of the cricoid cartilage. The laryngeal pharynx, the inferior-most region of the pharynx, extends from the epiglottis, at the level of the hyoid bone, to the esophagus, at the level of the inferior border of the cricoid cartilage. Anteriorly, it begins at the larynx, whose aperture appears to be guarded by the epiglottis immovable, flap-like structure. The epiglottis is connected to the midline and side of the pharyngeal root of the tongue by the median and lateral glossoepiglottic folds, respectively. The resultant fossa on either side of the median glossoepiglottic fold is known as the epiglottis vallecula. Inferior to the laryngeal opening, the anterior wall of the laryngeal pharynx consists of the posterior, mucosa-lined aspect of the arytenoid and cricoid cartilages. The mucosal aryepiglottic fold connecting the epiglottis to the arytenoid cartilage constitutes the lateral boundary of the opening of the larynx. Lateral to this fold is a fossa, the pinform recess, whose lateral border is the thyroid cartilage with its thyrohyoid membrane. The internal laryngeal nerve and its branches pass just deep to the mucosal floor of this recess. Pharyngeal wall. The pharyngeal wall consists of an innermost mucus layer, a middle fibrous and muscular layer, and the outer fibrous layer. Lying deep to the mucosa is the pharyngobasilar fascia attached to the base of the skull. It also attaches at various bony or cartilaginous structures along its path. Finally, it attaches to the pharyngeal raphe, a longitudinal fibrous band on the posterior wall of the pharynx. Pharynx. The laryngopharynx, specifically the piriform recess, is a common site for lodging of sharp objects, such as chicken and fish bones. The presence of foreign material in this region causes gagging, and the person is unable to remove the irritant. Care must be exercised in working in the piriform recess, for deep to the mucous membrane is the internal laryngeal nerve, which may be damaged during probing procedures. The pharyngeal wall is composed of 3 layers, an innermost mucous layer, a middle fibrous and muscular layer, and an outer fibrous layer. The mucosa lining the pharynx is continuous with the mucosa of the chambers into which the pharynx opens. Hence, it is either a respiratory or an oral type of mucosa. Just deep to the mucosa is the pharyngobasilar fascia, a layer of fibrous connective tissue that is especially thick craniad but dwindles as it progresses caudally. The cranial portion of the pharyngobasilar fascia has no muscular covering. It is attached to the base of the skull at various points, at the basilar portion of the occipital bone, anterior to the pharyngeal tubercle, at the petrotemporal bone, and at the medial pterygoid plate. Further anteriorly, it is attached to structures in the neck, thyroid cartilage, hyoid bone, stylohyoid ligament, and pterygomandibular raphe. A region of this fascia is attached posteriorly to a strong, longitudinally oriented, fibrous band of connective tissue, the pharyngeal raphe, which extends from the pharyngeal tubercle of the occipital bone almost to the caudal border of the pharynx. The constrictor muscles of the pharynx insert into the pharyngeal raphe. The muscular layer of the pharynx is positioned between the pharyngobasilar fascia and the thin, outermost layer of the pharynx, the buccopharyngeal fascia. Cranially, in the region devoid of the superior constrictor, this fascia fuses with the pharyngobasilar fascia. Nerves and vessels traveling along the pharynx course in the buccopharyngeal fascia. Muscles of the pharynx. In addition to the superior, middle, and inferior pharyngeal constrictor muscles of the pharynx, additional accessory muscles originate from other areas and insert into the pharynx. The musculature of the pharynx is composed of the superior, middle, and inferior pharyngeal constrictors as well as the stylopharyngeus, salpingopharyngeus, and palatopharyngeus muscles. The last muscle is discussed earlier in this chapter. The constrictor muscles partly overlap each other and may be visualized as 3 sleeves partially telescoped inside one another from superior to inferior. Superior pharyngeal constrictor. The superior pharyngeal constrictor is a thin, quadrilateral muscle whose fibers originate from the pterygoid hamulus and an adjoining region of the medial pterygoid plate, the pterygomandibular raphe, the posterior quarter of the mylohyoid line, the alveolar process of the mandible, and the lateral aspect of the root of the tongue. The muscle fibers curve posteriorly to insert into the pharyngeal raphe and pharyngeal tubercle. A thin slip of this muscle, couched on the internal surface of its cranial portion, passes lateral to the levator veli palatini muscle. It arises from the palatal aponeurosis and merges with the fibers of the main muscle mass of the superior constrictor. This muscle slip, the palatopharyngeal sphincter, produces a ridge, the bar of passivant, on the posterior pharyngeal wall, which is contacted by the elevated soft palate during deglutition, effectively separating the nasal pharynx from the oral pharynx. The superior constrictor, innervated by the vagus nerve via its contributions to branches of the pharyngeal plexus, acts to constrict the pharynx. Middle pharyngeal constrictor. The middle pharyngeal constrictor, a fan-shaped muscular sheet, originates on the lesser and greater cornua of the hyoid bone and the stylohyoid ligament. The cranial fibers pass superficial to the superior constrictor muscle, thus covering part of it. The inferior fibers pass deep to the inferior constrictor muscle. The middle constrictor inserts into the median raphe. The middle pharyngeal constrictor is innervated by the vagus nerve via its contributions to branches of the pharyngeal plexus and acts to constrict the pharynx. Inferior pharyngeal constrictor. The inferior pharyngeal constrictor, the caudal most of the 3 constrictors, envelopes the lower part of the middle constrictor. It arises from the lateral aspect of the cricoid cartilage, from the oblique line of the thyroid cartilage and the area behind it, to insert into the pharyngeal raphe. The caudal-most fibers of the inferior constrictor are continuous with the cranial-most, circular inner muscle fibers of the esophagus. The inferior constrictor receives its motor nerve supply from the vagus nerve via its contributions to branches of the pharyngeal plexus and from the external and recurrent laryngeal branches of the vagus nerve. Functionally, the inferior constrictor may be considered to have two parts, the superior thyropharyngeal and the inferior cricopharyngeal. The former constricts the pharynx, and the latter acts as a pharyngoesophageal sphincter, preventing reflux of esophageal contents into the pharynx. Stylopharyngeus muscle. The stylopharyngeus muscle, a long, thin, cylinder-shaped muscle, arises from the styloid process of the temporal bone and passes inferomedially between the middle and superior pharyngeal constrictor muscles to insert in common with the palatopharyngeus muscle on the dorsal aspect of the thyroid cartilage. The stylopharyngeus is the only muscle to receive its motor innervation from the glossopharyngeal nerve. It acts to elevate the larynx and pharynx. Salpingopharyngeus. The salpingopharyngeus muscle is a thin, fusiform muscle arising from the inferior aspect of the cartilaginous auditory tube at its terminal end in the nasopharynx. The salpingopharyngeus passes inferiorly, deep to the pharyngeal mucosa, to insert into the muscular wall of the pharynx by interdigitating with the fibers of the palatopharyngeus muscle. The salpingopharyngeus is innervated by the vagus nerve via its contributions to branches of the pharyngeal plexus. It functions in elevating the pharynx and may assist in opening the auditory tube during deglutition. Vascular and sensory nerve supply of the pharynx. Pharyngeal branches from the external carotid artery, the maxillary artery, and branches of the facial artery supply the pharynx. The caudal portion of the pharynx is supplied by the superior and inferior thyroid arteries. Arterial supply of the cranial portion of the pharynx is derived from the ascending pharyngeal branch of the external carotid artery, the pharyngeal branches of the maxillary artery, and the ascending palatine and tonsillar branches of the facial artery. The superior thyroid and, to a lesser extent, the inferior thyroid arteries supply the caudal portion of the pharynx. Venous drainage is via a plexus of veins, the pharyngeal plexus, located between the prevertebral fascia and the constrictor muscles. This plexus is drained by the pterygoid plexus of veins and the internal jugular and facial veins. Sensory nerve supply. Sensory nerves to the naso and oropharynx are branches of the maxillary division of the trigeminal and glossopharyngeal nerves, whereas the sensory supply to the remainder of the pharynx is supplied by the glossopharyngeal and vagus nerves. Sensory innervation of the nasopharynx and part of the oropharynx is via branches of the maxillary division of the trigeminal and glossopharyngeal nerves. The remainder of the pharynx is supplied by branches of the glossopharyngeal and vagus nerves. In addition, as indicated previously, overlapping innervation in the region of the fauces is provided by the facial nerve via its greater petrosal branch. The esophagus. The esophagus serves as a passageway for food from the pharynx to the stomach. The trachea lies anterior to it and the groove between these two structures is a passageway for the recurrent laryngeal nerve. The esophagus is a 25 cm long muscular tube whose main function is to serve as a passageway for food from the pharynx to the stomach. Along its length, the esophagus resides in the neck, thorax, and abdomen. It once situated somewhat anterior to the bodies of the vertebrae, until it pierces the diaphragm to enter the abdomen. The lumen of the esophagus is normally closed in its cervical and abdominal portions, whereas the thoracic portion is usually partially patent and contains air. The esophagus is in close association with various important structures along its descent through the neck and thorax, but only its cervical relations will be considered here. It begins at the level of the sixth cervical vertebra, as a continuation of the pharynx, near the inferior border of the cricoid cartilage, where the esophagus lies on the prevertebral fascia over the longus colli muscle. The trachea lies directly anterior to the esophagus, thus creating a tracheo-esophageal groove in which the recurrent laryngeal nerve makes its ascent. Lateral to the esophagus is the carotid sheath, with its neurovascular contents. The thyroid gland, specifically its lateral lobes, is also in close association with the lateral aspect of the esophagus. Although the microscopic anatomy of the esophagus is not pertinent to the study of its gross morphology, mention should be made of the fact that the external muscular layers are composed of skeletal muscle in the cervical portion of the esophagus, smooth muscle in the lower thoracic and abdominal regions, and a combination of the two in the upper and middle thoracic regions. Vascular supply of the cervical portion of the esophagus is via the inferior thyroid arteries and veins, and its nerve supply is derived from the recurrent laryngeal nerve, a branch of the vagus nerve, and the cervical sympathetic trunk. Esophageal defects. A relatively common type of developmental defect of the esophagus is the tracheo-esophageal fistula, which usually occurs just cranial to or at the bifurcation of the trachea. This anomaly is less common in females than in males. The fistula provides esophageal, and occasionally gastric, contents with free access to the respiratory system. This defect is the result of abnormal partitioning of the esophagus and trachea by the tracheo-esophageal septum during embryonic development. The larynx. The larynx is continuous with the laryngeal pharynx and the trachea. It is composed of several cartilages, intrinsic muscles, membranes, and ligaments that, acting in concert, control the inspiration and expiration of air between the laryngeal pharynx and the trachea. It also functions as the organ of phonation and modulation of sound. The larynx, or voice box, is continuous with the laryngeal pharynx cranially and with the trachea caudally. It is a passageway for inspired and expired air, a sphincter preventing the entry of solids or liquids into the respiratory system caudal to itself, and an organ of phonation permitting the production and modulation of sound. It is composed of a series of cartilages, muscles, membranes, and ligaments that, acting in concert, accomplish these functions. It is interesting to note that the larynx of the male and female are the same size before puberty. However, in adults the male larynx is larger than that of the female. The larynx lies anteriorly in the midline of the neck and is covered by skin, the infrahyoid group of muscles, and associated fascia. The great vessels of the neck pass posterolateral to it. It is lined by a mucous membrane, which is continuous with and similar to those of the pharynx and trachea. This membrane is modified in places to form two pairs of folds, the cranially positioned ventricular fold, false vocal folds, and the caudally placed vocal folds, true vocal folds, the latter overlying the vocalus muscles and being responsible for the formation of sound. It is convenient to describe the cavity of the larynx as consisting of three compartments: the vestibule, the ventricle, and the infraglottic cavity. The vestibule extends from the superior laryngeal aperture, adytus, to the rhemoglottitis, the space between the two true vocal folds and the two arytenoid cartilages. The ventricle is a space lying directly between the ventricular and vocal cords, being lateral outpocketings of the vestibule. The infraglottic cavity is the space between the rhemoglottitis and the beginning of the tracheal cavity. Laryngeal cartilages. 9 cartilages make up the framework of the larynx: the unpaired thyroid, cricoid, and epiglottic cartilages, and the paired arytenoid, cuneiform, and corniculate cartilages. Most of these cartilages serve as origin or insertion sites for the intrinsic muscles. Thyroid cartilage. The thyroid cartilage is composed of 2 quadrilateral plates, the right and left laminae, which fuse to form the laryngeal prominence, Adam's apple, of the neck. The angle of fusion is more acute in the male than in the female, accounting for the sexual dimorphism evidenced by this structure. Superiorly, this prominence ends in the superior thyroid notch and, inferiorly, in the inferior thyroid notch. The superior and inferior borders of each lamina end posteriorly in a superior and inferior cornu, respectively. The posterolateral surface of the cartilage bears the oblique line, extending from the superior to the inferior thyroid tubercles. The medial surface of the thyroid lamina is smooth and unremarkable. inclined apex to which the corniculate cartilage attaches, and 3 surfaces that provide attachments for muscles and ligaments. The base has 2 free processes, the lateral angle, which is the muscular process, the point of insertion for the posterior and lateral cricoretinoid muscles, and the anterior angle, or vocal process, to which the vocal cord attaches. The posterior surface serves for the attachments of the transverse arytenoid muscles. The ventrolateral surface presents a superiorly positioned, triangular fovea containing mucus glands and providing attachment to the vestibular ligament. Positioned inferiorly is an oblong fovea that is the site of attachment for the vocalus and, frequently, the lateral cricoretinoid muscles. The medial surface is smooth and is invested by a mucous membrane. Corniculate and cuneiform cartilages. The corniculate and cuneiform cartilages are tiny pieces of elastic cartilage. The former articulates with the arytenoid apex, whereas the latter is attached to the aryepiglottic fold just anterior to the corniculate cartilage. Membranes, ligaments, and muscles. The larynx is composed of several membranes and ligaments, which are associated with the muscles that move the cartilages. Tensions and movements of the vocal ligaments and vocal cords modulate the air passage through the larynx, producing audible sounds. Deep to the laryngeal mucosa is a thick, intrinsic membrane of elastic lamina whose cranial portion is referred to as the quadrangular membrane and whose caudal portion is the elastic cone. The inferior free edge of the quadrangular membrane assists in the formation of the ventricular vocal cords. The elastic cone has a well-defined anterior portion, known as the median cricothyroid ligament, and 2 thickened lateral portions, the vocal ligaments, whose free edges assist in formation of the vocal cords. 2 extrinsic membranes of interest are the thyrohyoid and cricothyroid membranes. The former is a thick, fibroelastic membrane suspended between the body and greater cornua of the hyoid bone superiorly and the cranial aspect of the thyroid cartilage inferiorly. It becomes thicker in its median portion, thus its name, median thyrohyoid ligament, whereas the lateral portions are called lateral thyrohyoid ligaments. The median cricothyroid ligament is a narrow band of fibroelastic tissue connecting the superior rim of the cricoid cartilage with the inferior rim of the thyroid cartilage. Issuing from the inferior rim of the cricoid cartilage and attaching to the superior rim of the first tracheal cartilage is the cricotracheal ligament. Muscles of the larynx. The muscles of the larynx may be classed into extrinsic and intrinsic groups. The extrinsic muscles have been described previously. There are 6 bilateral pairs of intrinsic muscles. The intrinsic muscles of the larynx are the cricothyroid, lateral cricoretinoid, posterior cricoretinoid, arytenoid, and thyroretinoid, and the vocalus. Cricothyroid muscle. The cricothyroid muscle is situated on the ventrolateral aspect of the larynx, bridging the space between the cricoid and thyroid cartilages. It originates on the arch of the cricoid cartilage and fans out to insert onto the inferior margin of the lamina and the inferior cornu of the thyroid cartilage. The external branch of the superior laryngeal branch of the vagus nerve supplies the cricothyroid muscle. This muscle acts to elevate and tip the thyroid cartilage ventrally, thus placing tension on the vocal cords. Lateral cricoretinoid muscle. The lateral cricoretinoid muscle is a small muscle originating on the arch of the cricoid cartilage to insert onto the muscular process of the arytenoid cartilage. This muscle is frequently fused with the thyroretinoid muscle. Inferior laryngeal branches of the recurrent laryngeal nerve, a branch of the vagus nerve, supply motor innervation to this muscle. The lateral cricoretinoid muscle acts to adduct the vocal cord by rotating the vocal process of the arytenoid cartilage in a medio-inferior direction. This movement approximates the 2 vocal cords, narrowing the rima glottis. Posterior cricoretinoid muscle. The posterior cricoretinoid muscle arises from most of the inferomedial aspect of the cricoid lamina to insert on the muscular process of the arytenoid cartilage. It receives motor fibers from the inferior laryngeal branches of the recurrent laryngeal nerve, a branch of the vagus nerve, and acts to tense the vocal cords and draw them away from each other. Arytenoid muscle. The arytenoid muscle, located on the dorsal aspect of the arytenoid cartilages, consists of transverse and oblique portions. The transverse portion, transverse arytenoid, is attached to the posterior surface of the lateral aspect of the two arytenoid cartilages. The oblique portion of the arytenoid muscle, oblique arytenoid, consists of two slender muscular filaments that cross over each other on the dorsal surface of the transverse arytenoid muscle. The oblique portion originates on the muscular process of one arytenoid cartilage to insert on the apex of the next. The muscle fibers frequently continue in the aryepiglottic region of the quadrangular membrane. This portion of the muscle is then called the aryepiglotticus muscle. The arytenoid muscle is innervated by the inferior laryngeal branch of the recurrent laryngeal nerve, a branch of the vagus nerve. This muscle draws the arytenoid cartilages toward each other, thus closing the rhemoglottitis. Thyroarytenoid muscles. The thyroarytenoid muscle is located on the lateral aspect of the larynx deep to the thyroid lamina. It originates on the medial aspect of the thyroid lamina and from the cricothyroid ligament to insert into the lateral margin and base of the arytenoid cartilage. The thyroarytenoid muscle is innervated by the inferior laryngeal branch of the recurrent laryngeal nerve, a branch of the vagus nerve. This muscle adducts the vocal cords. Vocalus muscle. Although some authors do not recognize the vocalus muscle as a separate entity, it will be so recognized here. The vocalus is described as arising from the thyroid lamina and cricothyroid ligament to insert into the lateral margin and base of the vocal ligament. It is often regarded as a slip of the thyroarytenoid muscle that inserts into the vocal process of the arytenoid cartilage and is attached to the vocal ligament. The thyroarytenoid and the vocalus muscles are innervated by the inferior laryngeal branch of the recurrent laryngeal nerve. These muscles act on the arytenoid cartilages and vocal ligament to decrease the rhemoglottitis by approximating the vocal cords. Movements of the vocal folds. Movements of the vocal folds toward each other, adduction, or away from each other, abduction, either open or restrict the air passage through the rhemoglottides, thus causing the tensed vocal folds to vibrate differentially, thereby producing sounds of various pitch. The vocal folds may be adducted, that is, moved toward each other, so that the intervening space, the rhemoglottitis, is almost obliterated. They may also be abducted, that is, moved apart, so that the rhemoglottitis is opened. Air passing from the trachea through the rhema vibrates the tensed vocal folds, producing sounds. The rhemoglottitis may be thought of as having two regions, an intermembranous region, between the vocal folds, and an intercartilaginous region, between the arytenoid cartilages. During normal breathing, the intermembranous portion is triangular and the intercartilaginous portion is rectangular in outline. During forced breathing, the arytenoid cartilages are rotated laterally so that the vocal folds are abducted greatly, describing a triangle whose apical angle is less acute than in normal respiration. The intercartilaginous portion of the rhema also becomes triangular, thus the rhema is shaped like a rhomboid. During phonation, the rhema is reduced to a thin slit in both its intermembraneous and intercartilaginous portions, and the vocal folds are tensed by the cranial tilting of the cricoid cartilage by the cricothyroid muscle. The pitch of the sound is directly dependent on the degree of tilting. During soft speech, the intercartilaginous portion of the rhema opens, whereas the intermembraneous portion is almost obliterated. Vascular and nerve supply. Vascular supply. The vascular supply to the larynx is provided by branches from superior thyroid artery and a branch of the thyrocervical trunk. Venous drainage of the larynx is via the superior and inferior laryngeal veins. The arterial supply of the larynx is derived mainly from the superior thyroid artery and the inferior thyroid branch of the thyrocervical trunk. These vessels provide superior and inferior laryngeal branches, respectively, which vascularize the larynx. The cricothyroid branch of the superior thyroid artery also serves the larynx. Venous drainage is accomplished by the superior and inferior laryngeal veins, tributaries of the superior and inferior thyroid veins, respectively. Sensory and motor innervation. Sensory and motor innervation to the larynx is provided by several branches originating from major branches of the vagus nerve in the neck and from recurrent branches of the vagus arising within the thorax. Sensory innervation of the larynx, above the vocal cords, is via the internal laryngeal branch of the superior laryngeal nerve of the vagus. The internal laryngeal nerve accompanies the superior laryngeal branch of the superior thyroid artery, pierces the thyrohyoid membrane, and distributes deep to the mucosa of the epiglottis, aryepiglottic fold, and larynx. Taste buds of this region are also supplied by the internal laryngeal nerve. Sensory innervation below the vocal cords is via sensory fibers of the recurrent laryngeal branches of the vagus nerve. Motor innervation of the larynx has been detailed earlier, but, in summary, all intrinsic muscles of the larynx except the cricothyroid are innervated by the recurrent laryngeal branch of the vagus nerve. The cricothyroid muscle is served by the external laryngeal branch of the superior laryngeal nerve, a branch of the vagus nerve. The trachea begins at the inferior border of the larynx and continues into the thorax, where it bifurcates into right and left bronchi. It is a membranous structure whose patency is maintained by incomplete cartilaginous rings. Heimlich maneuver. Foreign objects, such as a piece of meat, can be aspirated into the inlet of the larynx and become lodged in the laryngeal vestibule above the vestibular folds, causing muscle spasms that tense the vocal folds, thus closing the rima glottis. At this point, depending upon the degree of constriction, air movement into the trachea is restricted or may be completely obstructed from entering the trachea. The individual may start choking and perhaps will be unable to speak. The obstruction may result in complete asphyxiation and the person may die within approximately 5 minutes. Depending on the severity and condition of the patient, the Heimlich maneuver is performed to dislodge the obstruction by sudden compression of the abdomen to force a blast of air out of the lungs through the trachea and into the larynx, expelling the foreign object. When this procedure is unsuccessful, an emergency airway must be made into the trachea with a large bore needle through the cricothyroid ligament. Larynx. The intrinsic laryngeal musculature is served by two nerves, the inferior laryngeal branch of the recurrent laryngeal nerve and the external branch of the superior laryngeal nerve, both branches of the vagus nerve. Because these two nerves are prone to damage, it is essential that they be protected from injury during surgical procedures. The external laryngeal nerve, passing deep to the superior thyroid artery, supplies only a single muscle, the cricothyroid. Its section does not cause laryngeal branch of the superior laryngeal nerve, a branch of the vagus nerve. The trachea. The trachea begins at the inferior border of the larynx and continues into the thorax, where it bifurcates into right and left bronchi. It is a membranous structure whose patency is maintained by incomplete acatrilignous rings. Excessive damage to phonation. It will, however, affect the ability to tense the vocal cords and the ability of the patient to produce high-pitched sounds. In addition, damage to it causes some hoarseness and easy tiring of the voice. Damage to the recurrent laryngeal or the inferior laryngeal nerves will result in serious complications, whose severity depends on the degree of damage and whether the injury is bilateral. Involvement may range from slight hoarseness to complete inability to vocalize and breathe, necessitating performance of a tracheotomy. Tracheotomy. Tracheotomy is a surgical procedure performed to provide an airway passage to relieve dyspnea. This procedure is now generally used only for long-term maintenance of airway passage. Although the procedure may be performed any place along the trachea between the cricoid cartilage and the jugular notch, several complications may result because of the possibility of severing major venous channels and the isthmus of the thyroid gland overlying the trachea. A much safer emergency procedure for opening the airway is cricothyrotomy, in which opening the passageway is accomplished by incising the cricothyroid membrane between the thyroid and cricoid cartilages. This procedure is easily performed, having few possible complications. The trachea begins at the inferior border of the larynx, to which it is attached by the cricotracheal ligament. The trachea enters the thoracic cavity, where it bifurcates, forming the right and left bronchi. The cervical portion of the trachea is superficial, being only partially covered by the infrahyoid muscles. Its superior portion may be palpated between the sternal heads of the sternocleidomastoid muscles as well as in the jugular notch. It is a membranous structure, whose lumen is maintained by incomplete cartilaginous rings distributed more or less evenly along the length of the tube. The complete portion of the ring is placed anteriorly, and the posteriorly placed interval contains smooth muscle fibers that are able to regulate the size of the lumen to a limited extent. Deglutition, swallowing, is a complex and incompletely understood process. Generally, there is agreement that the process, though continuous, is divided into 3 stages: voluntary, involuntary, and final stages. Deglutition, or the act of swallowing, is a complex neuromuscular phenomenon that is only incompletely understood. For this reason, the anatomy of deglutition is an area rife with disagreement. The present discussion focuses on generally accepted aspects of deglutition. Although the act of swallowing, once initiated, is a continuous process, it is divided into 3 phases here for the sake of convenience: voluntary, involuntary, and final stages. The voluntary, or first, stage involves formation of the bolus of food by the actions of the tongue against the hard palate and by the slow stance of the soft palate as it approximates the back of the tongue. Once the bolus is ready, the suprahyoid muscles fix the hyoid bone and the tongue forces the bolus through the oropharyngeal isthmus. The involuntary or second stage of deglutition is irradiated when the bolus enters the oral pharynx. The levator veli palatini and tensor veli palatini muscles elevate and tense the soft palate, which comes into contact with the bar of passivant, thus isolating the nasopharynx from the oral pharynx. The final stage of deglutition begins when the inferior constrictor muscle contracts, thereby forcing the bolus of food into the esophagus, whose cranial portion is completely relaxed. The esophagus, via its musculature, then performs peristaltic actions to transmit the bolus of food into the stomach. The actions of the tensor veli palatini and salpingopharyngeus muscles also open the auditory tube. The paired palatoglossus muscles also contract, bringing the palatoglossal folds in close proximity to the back of the tongue. Thus, the bolus cannot pass laterally, superiorly, or ventrally, only inferiorly. Simultaneously, the stylopharyngeus, palatopharyngeus, salpingopharyngeus, and thyrohyoid muscles elevate the larynx and pharynx in a dorsal direction, approximating the laryngeal part of the pharynx to the descending bolus and pulling the laryngeal inlet out of the way. To protect the larynx, the aryepiglottic, thyroretinoid, and oblique arytenoid muscles contract to bring the aryepiglottic folds medially, creating a chute leading to the piriform recess. The bolus of food, sliding along the sides of the epiglottis, descends via the chute to the piriform recess.
Don't stop. 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 Don't. Don't stop.